Hospital-acquired fungal infections. Do they really exist? Yes, we know Candida parapsilosis and Candida auris. They are spread through the hands of healthcare workers. So we know Candida and Aspergillus. They are the most common and most important invasive fungal infections occurring in ICU patients all across the globe. And Candida has a specific risk factor like use of broad spectrum antibiotics, ICU admissions, diabetic patient, presence of a central venous catheter, and neutropenia. Similarly, Aspergillus is acquired and by inhalation, and there is respiratory involvement most commonly in neutropenic patients, and therefore patients are kept in a protected environment. But this publication in one of the journals shows post 2004 tsunami in Sri Lanka, there was a nosocomial outbreak of Aspergillus fumigatus by epidural anesthesia, and here they were all pregnant women they were due for cesarean sections, and here the syringes stored in a dingy store were contaminated. That was the source. So these smallest details sometimes we tend to miss. Then mucor has been associated again with the hospital supplies like linen, dressing material, the tapes, splints, the spatula. All these can be contaminated, and directly cutaneous involvement even in newborns have occurred with several deaths. Then fusarium is another important highly fatal infection. It can be transmitted through contaminated air and water supplies. So fungal outbreaks are more common than most people appreciate, and CDC investigates 3 to 6 fungal outbreaks per year, many of which are caused by rare fungi with limited diagnostic and treatment options. Recently, in May 2023, in Matamoros, Mexico, during medical tourism for cosmetic surgeries, an outbreak of fungal meningitis has occurred. It is because of Fusarium solani, and CDC and WHO had to declare public health emergency of international concern. Interim recommendations for diagnosis and management of cases of fungal meningitis were released, and they are still available, and people were asked who had sought treatment at 2 hospitals in Mexico during January to May, and they were asked to go through a lumbar puncture even if they were free of any symptoms. So healthcare associated fungal outbreaks keep occurring, and new and uncommon species are commonly being recognized because of availability of new molecular tools. So here are few interesting cases. One is a large outbreak with Saprochaete clavata, which was earlier known Geotrichum clavatum, and it is closely related to Magnesiomyces capitatus. So they both are resistant to echinocandins and often misdiagnosed. So there have been reports of contaminated dairy products responsible for Magnesiomyces outbreaks in hematology patients. This outbreak occurred in France in several different districts over 1 year period with 2 clades of Saprochaete clavata. And the source was not identified in this outbreak, and it spontaneously disappeared. Whereas Saroclinium kilians, which is normally responsible for superficial or subcutaneous infections, or it is related with catheter-related fungemia, led to an outbreak in 2 countries, Colombia and Chile, during 2013-2014, and this was associated with receipt of contaminated anti-nausea medication supplied by one supplier, one manufacturer, and the drug was ondansetron. Another outbreak, uh, which is almost historical, Xerohilum rostrinum, it is a black fungus, normally a soil saprophyte. It is rarely associated with superficial infections. Led to outbreak of fungal meningitis in US during 2012 to 2013, and it involved different states. The source of fungal meningitis outbreak was traced to one supplier of injectable methylprednisolone acetate product, which was contaminated with the fungus. And in 1 year period, 751 patients were infected and 64 deaths occurred. This was the uh, involvement of cluster, and meningitis was the commonest manifestation in these patients. Earliest manifestation was stroke without documented meningitis, and it was difficult to identify these patients, but because of molecular diagnosis it helped them. Then next common was meningitis, then spinal and paraspinal infections, and peripheral joint infections. So we have to remain alert, and we have to use these molecular diagnostic tests to identify such clusters. Recently, there is an alert in USA that there is a dramatic increase in cases of Candida auris from 2016 to 2021, with a rapid rise of cases by 60%. And there is also increasing cases with echinocandin resistance, which is the first line of agent, and it is the only drug used for Candida auris. So this has been published in March 2023, and this graph also shows the rise in cases despite good infection control practices being followed because of this emergence, and it carries a high mortality of 60%. So there are interim guidelines, there are expert recommendations for prevention and management of Candida auris transmission. And they say that Chrome agar Candida plus should be used for initial screening because it shows these specific colonies with a beautiful blue rim, and reverse is also blue. The all Candida isolates should be identified by MALDI-TOF if possible. Otherwise, speciation and antifungal susceptibility testing should be done for all Candida isolates in high-risk patients. And if there is a single patient should be isolated, and there should be one-to-one care, and staff should be adequately trained to prevent further spread in the hospital, because this behaves like a superbug. It is a multi-drug resistant organism with high mortality, and it leads to nosocomial outbreaks. It survives in the environment for prolonged period on inanimate objects, and it is transmitted with the hands of healthcare workers and through the commonly used equipments. And it is resistant to some disinfectants like quaternary ammonium compound, which is used for disinfecting the ultrasound probes, and they cannot be cleaned with alcohol wipes, so hydrogen peroxide is recommended for cleaning the probes. And so we have to upgrade our disinfection policy as well, besides good infection prevention and control strategies. And if there is a transmission in the hospital, then multidisciplinary outbreak team is formed, and administration is involved stringently for controlling the further spread. So in Candida auris, candidemia is very much present in Indian ICUs, and these are the risk factors: presence of a CBC, urinary catheters, recent surgeries, and diabetes mellitus. And for resource limited uh, hospitals, medium has been researched, and it is selective auris medium SAM, which can be utilized easily to identify these isolates. There's yet another Candida, that is Candida parapsilosis, which has emerged just like Candida auris as a MDRO, which is leading to nosocomial outbreaks in the hospitals, and it has changed its patient profile. It is normally reported to involve premature neonates or neutropenic patients, but in these outbreaks, it has caused severe infection in adults, and especially by fluconazole-resistant strains with a high mortality rate, and there was this spread despite strict infection control strategies. And this azole resistance was found in azole naive patients who had never received azoles. There's another concern now in 2020 where they are showing echinocandin tolerance. So we were already handling Candida auris unsuccessfully, and another uh, Candida has emerged equally threatening for the population, of a grave public health concern. And there are increasing publications 2018 onwards. These are the number of publications, and these are this line shows the involvement of countries with such Candida parapsilosis, which is resistant to fluconazole. Fluconazole is the only available oral agent which is widely available for managing candidemia in resource limited countries, where the problem of this nosocomial outbreaks, which is usually undetected, is more. Another important fungi which is emerging and being studied for its relation with nosocomial outbreak is Pneumocystis jirovecii. It occurs in corticosteroid use, and when there is a defect in CMI in patients, especially with solid organ transplant. It has been seen in renal transplant units, also associated with neutropenic patients of hematology, chemotherapy, rheumatology patients, and even with malnourishment. So there is a fulminant respiratory distress with fever and dry cough in these immunocompromised patients, whereas in HIV/AIDS patient it has more indolent infection. So on radiology, there is bilateral diffuse interstitial pulmonary lesions, and beta D glucan test has a good negative predictive value. But to differentiate from colonization, nested PCR or real-time PCR is required. So it has a higher mortality in these non-HIV immunocompromised patients in comparison to AIDS patients, and it has led to multiple outbreaks, and these outbreaks have been studied with molecular tools. So because of these outbreak settings, we need to devise chemoprophylaxis strategies and good infection control isolation precautions. So in one Scottish renal transplant center, they studied and found that those who developed PCP were more likely to have shared a hospital visit with another patient who went on to develop the infection. So there was 37% versus 19% rate, almost double in patients who went together. Usually this manifests after a long interval of more than 4 years, and there is a documented potential person to person transmission. So for any outbreak investigation, these are the 3 steps we need to take. 1, to identify the potential source, we need a descriptive epidemiology. Then hypothesis is tested with analytical epidemiology, and diagnosis is confirmed by molecular typing. So a line listing of cases should be formed with all these details, including outcome and date of discharge or death. And molecular typing is the answer. MLST or whole genome sequencing has been used for all these recent outbreaks, and in resource limited countries, AFLP can be a good substitute. So carry home message to prevent fungal HAIs is there should be an alertness for cluster of patients. They can be spread over months to years, and a line listing should be prepared for these patients. Molecular typing is the standard method to identify them, and they can be common like Candida parapsilosis, Candida auris, Aspergillus, Mucorales, Fusarium, to unusual causative agents. It is difficult to prove environmental sources because usually one spore is able to cover up the whole culture plate. So in single exposure outbreaks only we can identify the particular strain. Otherwise in the environment multiple strain of the same species can be present and they can be missed. A very important need, especially in developing countries in India, is regular cleaning and maintenance of hospital air supply system, that is HVAC. And concentration of fungal spores in indoor air should be less than the outdoor air. No mold should be acceptable on the walls or roofs of hospitals and of air ducts. Whenever there is any construction activity being done, maintenance, renovation or repair, proper infection control risk assessment should be done and good infection prevention control measures should be applied. Environmental engineers are involved and they are responsible to prevent such outbreaks. And of course, hospital administration plays a major role for this. With the recent flooding and different natural disasters occurring like earthquake, volcanoes, tsunamis and cyclones, more cases of these outbreaks will be seen because increased dampness at the storage site of medical supplies. So we have to remain vigilant and keep reading more material available online on such issues. Thank you.